I have just started the recording of this open meeting in compliance with CMS. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting and consented on behalf of the Palmetto GBA. So at this point, let's go ahead and begin our open meeting with our first presenter. Looks like Dr. Kalia. If you'd go ahead, sir.
Yeah, good morning. This is Hemant Kalia. I'm one of the interventional pain doctors in upstate New York. Today I will be representing American Society of Pain and Neuroscience. Can I share my screen? So I would like to thank, first of all, for allowing us to give this presentation today. And we represent more than 4,000 members across who actually perform this procedure and discussion across the disciplines of interventional pain management, neurosurgery, orthopedic spine surgery, physiatry, interventional radiology, and also our public health and preventive medicine colleagues. And over the next 5-10 minutes, I would like to focus on specifically the procedure of a posterior SI joint arthrodesis not using a transfixation device. And hopefully we'll be able to provide some additional new evidence and also share our guidelines through our Aspen Society regarding the two CPT codes in discussion 27278 and 27279. All right, this looks good. These are my disclosures. As you can see, nothing pertaining to the topic of discussion today. I'm sure we are all experts in this specific pathology of SI joint dysfunction. And if we talk about chronic low back pain patients, about 30% of these patients, roughly about 1 in 3, SI joint can be the pain generator for these patients, contributing to their overall pain presentation. So the question is, are all these patients candidate for SI joint fusion? Absolutely not. I think most of these patients respond really well to conservative treatment options. Next slide. But there is still a small subset of patients who would stop responding to these conservative treatment options. And in rightly selected patients, they would benefit from these minimally invasive advanced procedures to arthrodese or fuse the joint, which can help not only manage their pain, but also improve their function and quality of life. When we talk about minimally invasive procedures which can fuse the SI joint, we have a lot of options. The extreme option is the open procedure, and then we have the minimally invasive approaches, which is captured by two CPT codes 27278 and 27279. As mentioned earlier, we will be focusing on the posterior SI joint arthrodesis approach, which is not utilizing a iliac and transfixation device, and hopefully provide some additional evidence and make an economic case to for the patients who are suffering from SI joint dysfunction. Next slide. As you all recall, last year, the regional MACs actually determined SI joint ablation as experimental and investigational. So what has that specific approach has opened the Medicare beneficiaries to go through minimally invasive arthrodesis procedures for the SI joints. Hopefully in the next 2 to 3 minutes, I'll be able to make a case that if we restrict the access to posterior SI joint fusion technique, we will not only be devoiding the access to safe and effective treatment options for Medicare beneficiaries, we will be moving these Medicare beneficiaries to treatment options with high cost of healthcare delivery. Next slide. I do want to take about 30 seconds here and commend the wiseness and also the earnest approach of Medicare medical directors to come up with a really evidence-based approach to identify and diagnose SI joint dysfunction through these clinical, radiological, and interventional diagnostic options. So Aspen agrees with most of the clinical criteria is delineated in diagnosing and treatment of SI joint disorders. Next slide. So for minimally invasive SI joint fusions, as we know, we have few options. The LCD in question and discussion today talks about two specific approaches. One is through the transiliac approach using a transfixation device, and the other is a posterior approach, which does not use a transfixation device. If you look at the evidence, next slide, there is plethora of evidence ranging from case reports, case series, retrospective studies, and now we have level 1 prospective data focusing on the posterior SI joint fusion, which was recently published about 2 weeks ago for 12-month data points, and we'll go over some of those evidence in the Kolodny study in next few slides. But the overall evidence for the safety and efficacy of posterior approach to SI joint arthrodesis is now available to us. Next slide. When we talk about the safety of these posterior approaches, I think the first question which everyone asks is about how what kind of fusion these devices can obtain. And Dr. Syed's study, which was focused on the benchmark of biomechanical evaluation of fusion, clearly delineates that the fusion which actually occurs through these allografts is similar to the fusion which has been reported in the literature through lateral transarticular fixation. The second study kind of very nicely compares the fusion which is obtained by the allografts to that benchmark data published in the peer-reviewed literature. Next slide. The posterior approach has also been effective in salvaging the patients who are continuing to report SI joint related pain, who have other advanced treatment options like spinal cord stimulator, interspinal spacer, intrathecal drug delivery devices, and minimally invasive lumbar decompression procedures. So this also emphasizes the importance of an approach which helps salvage some of these patients who have gone through other therapies. Next slide. I do want to get into a little bit more detail on the level 1 data using a specific link device, which is used for posterior approach to arthrodesis SI joint. And this is not a transiliac approach, and this is not a transfixation approach. This study, as you can see, the goal was to design the efficacy and the safety of this specific device for posterior SI joint fusion. And the researchers followed these patients for 6 and 12 months. Their primary outcome was obviously to look at the improvement in the pain scores, but they also had secondary outcomes as improvement in the ODI scores. Next slide. The 12-month data was recently published about 2 weeks ago. And this is a really nice slide. You know, whenever we talk about evaluating clinical trials, I think it's important to have what we call a complete graph of all the patients which can be captured in this tornado graph. So one beauty of it is that you can see each and every single patient who participated in this study. So this was a single-arm, multi-center prospective study which looked at the safety and efficacy of this posterior arthrodesis device. You can see that about 73.5% of the patients continued to report at least minimum 20% improvement in their pain scores at 12-month interval. And most importantly, about 30% of the patients had a statistically improved mean over the baseline. So that's a really great response, which was statistically significant. It also behooves to mention here that there was no serious adverse event reported in this long-term prospective study. Next slide. They also looked at the ODI, and this slide nicely summarizes on the effect of this specific approach on overall functional improvement of these patients. About close to 21% of these patients continued to report a significant functional improvement by the end of 12 months. We at Aspen have taken the approach to evaluate the evidence, standard of care, and come up with specific guidelines for advanced minimally invasive procedures which help our chronic pain patients. And we are proud to report today that our practice guidelines focused on the SI joint, next slide, have been accepted and are currently in press. They should be available hopefully before the MAC here today makes the decision on the LCD. So we have very specific, strict methodology to evaluate the evidence and the standard of care. Next slide. What we propose and recommend is minimally invasive posterior SI joint stabilization with allografts is considered medically necessary when appropriate clinical criteria have been met. And we completely agree with the clinical criteria delineated in the current LCD, and our evaluation of that evidence is about 1-B, and our certainty of net benefit at the population level of this specific procedure through this specific approach remains high. Next slide. When it comes to other products, I think we skipped one slide. Okay. When it comes to other products, we recommend that all these products should comply with the guidelines put forth by FDA, and all these products should be FDA approved. Next slide. And last time I checked, I think there are about 32 products which are available in the market, which can help fuse SI joint through different approaches. After looking at the evidence as ASPN, we recommend that these devices should publish their efficacy and safety data through a prospective multi-center study with minimum of 6 months in a peer-reviewed literature. I do want to quickly make a quick comment on the health economics. And these are the rates published versus at about $11,934, and 27279 does not have any allowance of the procedure to be done at the office level. So hopefully this slide kind of summarizes the fact that if we restrict coverage of 27278, which is the posterior SI joint arthrodesis without transfixation devices, we will be moving the healthcare cost utilization to a higher level of site of service and higher level of overall care for Medicare beneficiaries. Next slide. So to summarize, I think we have a posterior fusion product which is biomechanically and clinically competitive in efficacy to the benchmark lateral approach for fusion. The level 1 study by Dr. Kolodny has proven the safety of this procedure. And when it comes to the coverage of that specific procedure in this LCD in question, next slide, we would strongly recommend deleting the statement of minimally invasive arthrodesis of the SI joint without placement of a transfixation device is not considered medically reasonable and necessary. Or our other recommendation would be to consider amending that statement where minimally invasive arthrodesis of SI joint without placement of a transfixation device is considered medically reasonable and necessary only when the medical criteria is delineated in the LCD has been established. Another consideration can be given to introducing a prior authorization process for both 27278 and 27279 CPT codes to ascertain utilization management. With that, I would like to end this presentation and yield my time to other presenters. And if there are any questions, then happy to take those questions right now or at the end of the presentation. Thank you.
Thank you, Dr. Kalia.
Is Stephen Foster on? I know he's our next presenter.
Dr. Foster, are you there somewhere? Melissa, I have not heard from Dr. Foster, so I suppose we should move on to the next presenter, which would be the minimally invasive arthrodesis of the SI joint by Dr. Sowen. I'm sorry.
All right. Well, thank you, everybody. Melissa and the Palmetto team graciously allowing me to speak. My name is Amol Soyen. I am speaking on behalf of ASIP, the American Society of Interventional Pain Physicians. And, you know, of course, we're going to be talking about the LCD deal 39797. And, you know, I'm going to start, of course, by thanking you for allowing me this opportunity and all of us this opportunity to discuss this LCD and sort of explain our rationale and point of view. Let's start with some introductions and outline some of the key issues that I'd like to talk about today, and then we'll kind of go from there. On behalf of ASIP, thank you. Sincerely, really, I'm not just saying that. I really appreciate the ability to participate and express our opinions and I suppose some of our concerns regarding the proposed LCD. Some of the issues that we would like to address today include a statement on behalf of NASS, the North American Spine Society, because I believe that will provide some context for everybody. And also, I know that some of that was utilized in drafting this LCD. At least that's my impression. I want to talk about a summation of all of the intra-articular allograft implants that are not transfixing devices. And you know, the ones that are, and review the data that actually was not addressed in your literature search, because I know that you guys have looked at that data, but there's some other stuff out there that I think is important because it can provide some context in terms of the number of patients that we're seeing, the number of patients that have been studied, and the number of studies that are out there. That really provides context, because I know we all want to be evidence-based, and if there's key evidence and items in the literature that were not included in the LCD, I think that might be a little bit problematic, so it's important to look at that. I want to discuss some clarification regarding statements of non-coverage LCDs, and then we'll discuss some statements by CPT for procedural description. So 27279 is a definition of transfixing. CPT did not change the code. Right? That's important when CPT met. One important thing about that code that I really want to get across here is that these codes are non-directional. As it is, that's how they're written. They are non-directional, and we noticed in the LCD there was directionality or directional statements used for coverage or non-coverage in that LCD. Which is somewhat of an issue, especially since the CPT code is non-directional. We believe that might be taking some editorial license that, in our opinion, is not necessarily appropriate when drafting an LCD to change the material aspect of the spirit of the law and the letter of the code. 27278, of course, intra-articular non-transfixing. And before I jump into it, I don't know, sometimes I like learning from analogies, and I want to tell you guys a little analogy of something that I'm pretty positive most of the people on Palmetto, or the 60-some people I see, or potentially more that are on this call, are probably going to do at some point this month. You know what that thing is? Eat a slice of pizza, right? So when you look at a pizza, I'm sure the first guy that made a pizza, this round little thing, thought about how are we going to eat this thing? And eventually, some genius came up with the concept of cutting the pizza into slices, right? there's a lot of ways to cut a pizza. You could take that pizza and you could tear it and rip it. It's pretty invasive and sloppy, kind of messy. You don't exactly get those uniform triangles you want. You could use a pair of pliers. Terrible idea, but you could, right? You could go down there and cut down with a pair of pliers a slice of pizza and eat it. At some point, somebody thought, hey, let's just use a big knife. And that sort of became the traditional approach, right? To slice your little pizza into pieces. And then someone came up with this super innovative way of taking a pizza cutter and kind of rolling it, which sort of became the standard for a while. Bottom line is there's a lot of ways to cut the pizza, but what really matters is, can you get that pizza cut safely, effectively, without cutting your fingers off, efficiently? And that's ultimately an analogy that we're going to come back to as we explain some of these procedures, some of these CPT codes, and some of this stuff here today. But before I get into that, let's talk about NASA's recommendations for SI fusion. Palmetto has stated under the analysis of evidence that you can see there that there's moderate quality evidence that MI arthrodesis and placement of a transfixion device is an acceptable option for patients with chronic dysfunction in the SI joint due to degenerative sacroiliitis, right? So we've established that. And implants are consistently associated with improved pain and disability from baseline without substantial safety concerns. That's important. That's a rationale for determination right there. The improvement appears to be sustained in the long term. So we have established that transfixing this device, or in other words, arthrodesis, or literally preventing movement of that joint, because that's essentially what transfixion does, is prevention of movement. We've established that, at least Palmetto has, upon analyzing the evidence, that it is improving pain and improving disability without safety concerns. Because of this issue, North American Spine Society reports that there's insufficient evidence to make a recommendation for or against SI fusion compared to medical treatment of low back pain due to dysfunction. Although this was stated as the opinion of NASS, there are actually no citations or context from where the statement originated. And actually, NASS published their most recent coverage statement and policy recommendations in September 2021, which actually stated the coverage recommendation is limited to the insertion of usually more than one structural device transversing the SI joint intended to fuse the bone or lead to fusion of the joint itself, right? So NASS has an updated coverage recommendation statement that you see here that actually recommends coverage for minimally invasive SI fusion when all 8 criteria have been met. And that's something that Dr. Kalia mentioned about those 8 criteria being met. Minimally invasive SI fusions have been shown to be relatively safe with a minimal estimated blood loss, low infection rate, low complication rate, low revision surgery rate. Much of the literature is subjected to bias, right? Because there's a lot of industry support. However, multiple SI fusion devices have shown similar results. And I know you guys mentioned that too, or not you guys, but whoever wrote the LCD mentioned that, there's a lot of industry bias. And I understand that point to a degree, but when you have multiple different studies across multiple different patients from multiple different clinical sites showing similar results, that's reproducible, repeatable, and in my opinion, that data at that point has integrity because it would take a lot of good people to tell a lot of lies to spin a story that was not accurate, if we were to believe that. Let's talk about the biomechanical properties of various devices. Distraction arthrodesis of an intra-articular approach, as stated in the proposed LCD, is not necessarily typical of all mechanism of actions because it varies by manufacturer. Distraction arthrodesis, which you heard about from Dr. Kalia, things like that Link device that published a really nice study very recently, 1-year data. There's also some 6-month data. PSIF, the Nadia device, which actually has some good data that I'm going to show you in a slide coming up, CER10 as well. There's other mechanisms of action, right? So not distraction arthrodesis, but this actually includes transfixing the joint from a posterior approach. Now, at the point that these are actually transfixing the joint, if you look at the previous slide, to me, this makes a lot of sense because at that point, we're actually literally fixing or fusing the joint, right? And we've sort of established that that is safe, effective, and all the stuff I just went over. So I won't necessarily go over it again, but we've sort of established that. Now, I also mentioned the important point about the CPT code being non-directional. That's important to think about here because even though it's a posterior approach, these are still transfixing the joint. And you see the names of them here: Catamaran, Tillink, SI joint, Silo, TFX, Versa V1, Corner Lock, which actually has a lot of data that I'm going to show you on a slide coming up here of a lot of different studies that will be coming out. And you can see on the bottom, biomechanical FDA required testing for standalone posterior approaches, 510K approved for transfixing the joint. We'll be providing that to Palmetto in written comments here. But this is an important slide. I don't know if I necessarily want to go over all of these, right? There's a lot of writing on here that's really small. Now, after I just turned 40, it's getting harder to read. I got to slide my glasses down to my nose, But some of these studies were not presented in Palmetto's consideration for study analysis. I mean, I just want this slide to be out there for everyone to see. Of course, a lot of this will get picked up in the public comments. But you can see that Omnia PSIF intra-articular allograft on 57 subjects, 12-month study, showed improvement in VAS with no serious adverse events. The Aurora Silo intra-articular allograft, 62 subjects, 6 months, also with significant improvement in pain. The Foundation Fusion Solutions Corner Lock intra-articular dual locking allograft. So dual locking, right? So two multiple different approaches as mentioned in the NAS guidelines, important to think about, and the fact that it's transfixing. But look at this, 115 subjects, 12 months, significant improvement in VAS score. Another one from Corner Lock was Force Center's retrospective case series. Only had 10 subjects, but still data over 12 months. And then there's another one again, using intra-articular dual locking allografts, 52 subjects, 28 responded prospectively. This was a single center retrospective, but also prospective case series. And then I mentioned that Nadia posterior distraction approach, with a little bit different. European study published in the European Spine Journal, 171 patients though, 24 months. I mean, outside of all the stuff that you looked at, I mean, here's some other data here. Dr. Kalia also presented this study, the SECURE study. And we're looking at so many different studies across multiple different groups from multiple different parts of the globe, showing significant improvement in VAS score over a long time. At some point, you kind of think that the data's got to be there for this. And we have already established that SI fusion or transfixing or preventing movement of the joint is an appropriate approach. Medicare is going to cover it just from a different directional approach. So it just seems kind of odd that we're sort of discriminating against a certain approach or angle. There's a lot of different ways to cut a pizza, right? Some people use a pizza cutter, some people use a knife. But the bottom line is, if you solve the initial problem of actually cutting the pizza in appropriate slices, you kind of wonder, like, okay, why is one pizza cutter necessarily covered and the other one isn't, right? You either blanketly agree that sacroiliac joint dysfunction, if you prevent movement of the joint, is an effective therapy, or you don't. And after that, if you establish that it is, which we have, and it seems you guys have, all of a sudden we're sort of nitpicking from directional approaches. It just seems a little bit odd, to do that. So when we look at the clarification for rationale for the non-coverage LCD, you can see that Palmetto states query of other payer LCDs reveal that those that have LCD on MIS for SI joint, dorsal approach access, et cetera, including use of implants other than those which are across the joint to promote fusion, is considered experimental or unproven. Now, this is a little bit confusing, that statement in the LCD, the proposed LCD, and to some extent problematic, because in review of the LCDs for MAC policies, for WPS, CGS, NGS, and Noridian, I went over all of them, there actually is no negative policy for MIS regardless of the SI approach. So I'm not sure the statement is actually factually accurate, which is somewhat problematic to have in an LCD, in my personal opinion. However, if Palmetto's referencing other policies, other payers, such as private payers like Cigna, Blue Cross Blue Shield of Massachusetts, United Healthcare, these other ones that are listed as a quote LCD, actually have concerns of that too, based on criteria of a Medicare administrative carrier, a MAC like Palmetto, utilizing the same investigational experimental criteria as a for-profit insurance company. And I do not understand how that would follow Title 18 of the Social Security Act, and you can see the reference there. I've been doing this for a while. I think I've been on a CAC since 2007 or something like that. For Ohio. And so, you see a lot of LCDs come through. This here kind of makes me feel that maybe this wasn't necessarily internally generated or was put together by a group or entity that somehow had nefarious intentions of potentially creating monopoly for their specific approach, because the cadence of this does not seem appropriate or consistent with how an LCD, in my opinion, is typically written. And I think that this statement is somewhat problematic. I mean, we all know we have to follow the specific titles of the Social Security Act when we're doing these things. Many commercial for-profit payers utilize cost effectiveness as a criteria for decision making. And CMS guidelines would not follow that for coverage decision making, right? CMS uses evidence-based data, importance of helping the population in terms of getting better, looking at the science and data, and not just for-profit interests. So clarification rationale for the non-coverage LCD, just continuing that. If reliance on commercial payers, the criteria is stated, below are a list of plans that do cover it regardless of approach. And this will be in sort of the public comments that we write for both transfixing and non-transfixing devices. So in summary, additional evidence was provided here today, and this will be delivered in written and our formal comments. But actually, after you calculate all of the number of patients, and we're talking across the globe. I mean, we showed one that was published in the European Spine Journal, and there's a lot of stuff going on here in the U.S. and even additional studies that have come out. I think these need to be considered. When you look at the compendium of that data, it's significant and robust. And the comment of industry funding is, I understand that problem and concern. I totally get that. But when you look at all of these different studies across multiple different platforms and all the different providers and all the different sites, at some point, data is data. Not all posterior implants are actually distraction arthrodesis. Some actually can be transfixing. That's important. CPT deemed 27279 and 27278 that are non-directional. This is an important point for me because the difference in codes is transfixing and non-transfixing. So I noticed in the LCD, there was a lot of directional comments written in there. And I feel like that was a rationale used.
Dr. Soen, I'm sorry to interrupt you. Is there any way we can go ahead and get this wrapped up? Because we do have to honorable times for everybody else. Thank you.
Got it. Okay. So I think basically I've kind of gone through it. I appreciate all you guys' time. Thank you very much. Have a great day. Hopefully you all enjoy a slice of pizza at some point and think about how you cut it. There's many different ways to do it as long as you get it done the right way, effectively and safely and accomplish similar goals. I think it's
all right. Thank you.
Thank you. Have a great day, everyone.
Melissa, let's go ahead and move on to the next presenter, Dr. Ladd, since he's next on the list. Thank you.
And just quickly, if I may, Melissa, this is Steve Foster at Tenna. My apologies to the panel. We had an electrical storm here in Nashville. I'm now through cell phone, so I'm available should the opportunity present.
Yeah, Dr. Foster, if we have time at the end, we'll let you go ahead and maybe you can go ahead and do your presentation. But in order to keep on time and to be fair to all the other participants, we'll go ahead and proceed with Dr. Ladd's presentation. Dr. Ladd, if you're ready, sir, go ahead.
Oh, wonderful. Sorry. My name is Dr. Daniel Ladd. Lots of Mohs experience, 8 years of experience treating non-melanoma skin cancer with image-guided superficial radiation therapy. I'm a former president of the American Osteopathic College of Dermatology, and I'm the Chief Medical Officer for Skin Cure Oncology. Today, I want to focus on 3 key areas in the proposed LCD. One is the role of radiation oncologists versus dermatologists in providing image-guided SRT. Number 2, the role of high-resolution dermal ultrasound in the treatment of low-risk and high-risk non-melanoma skin cancers. And lastly, image-guided superficial radiation therapy for non-surgical patients only. So in the provider qualifications under the proposed draft LCD, there's some contradiction there that we noticed. And it was the problem, I think, with the policy, the way it's drafted, was that it would further limit access to those Medicare beneficiaries most in need, like rural Medicare beneficiaries, while conflicting with the existing national and state laws and regulations. So the proposed LCD opposes its own opening statement on CMS national coverage policy, which states on page 2/17, all providers who report services for Medicare payment must fully understand and follow all existing laws, regulations, and rules for Medicare payment for the delivery of radiation therapy services for the treatment of non-melanoma skin cancer. In addition, any applicable state laws must be followed for the safe delivery of radiation therapy to the beneficiary, including any structural requirements RT is delivered and any applicable supervision or training requirements for staff participating in the delivery of radiation services. Finally, the radiation therapy services must be within the physician's scope of practice and consistent with any additional state regulations and guidelines. So, you know, the issue here is that the Palmetto proposed LCD, it seems to be attempting to create a far stricter list of qualifications than Medicare national policy as it exists today, or even Palmetto's own policies on other radiation services and select procedures. So that stood out, and we wanted to let that be known. The next issue is that we're worried that the proposed LCD as it stands might create a barrier. I think will definitely create a barrier for any provider entry, and it will significantly limit access to this proven treatment for those Medicare beneficiaries most vulnerable and in need of image-guided SRT as an option. So if you look at this chart here, you can see that image-guided SRT is now the standard radiation therapy for non-melanoma skin cancer. And the operators of this is primarily dermatologists, right? Dermatologists are almost the sole providers of superficial radiotherapy for non-melanoma skin cancer, and we've been that way for over 100 years. And so that's significant. What's also very significant is that 95% of rural counties in the United States lack access to a Mohs surgeon, and that means that those patients can't get the 99% cure rate. And those patients actually get a lot more skin cancers than some of their metropolitan counterparts. And so it becomes a very big issue. And, you know, allowing image-guided SRT to remain under the control of dermatologists will allow them to deliver higher efficacy rates to rural Medicare beneficiaries. So the LCD, the way it is, might limit access to highly effective and safe treatment of non-melanoma skin cancer for underserved Medicare recipients. So that's a big issue, I believe. And so, you know, based on the data, Wise and Palmetto focusing on nurse practitioners and PAs who are providing SRT, that might be more effective. So let's talk about the high-resolution dermal ultrasound and how that works and why that's okay to use in the treatment of low and high-risk non-melanoma skin cancers. So the proposed LCD states, number one, the use of high-resolution ultrasound may be reasonable and necessary for tumor staging and pre-planning purposes, right, to determine the depth, size, and stage of the tumor prior to the delivery of superficial radiation therapy. And that's fine. We agree with that. Where we take issue is where it says the continued use of high-resolution ultrasound during the fractionated treatment sessions is not reasonable and necessary, except for high-risk NMSCs. And I'll give a counter proposal that's more appropriate. The use of high-resolution ultrasound may be reasonable and necessary if it is determined there is a significant change in the status of the tumor during the ongoing SRT treatments, and imaging is required to adjust treatment dosing for high-risk non-melanoma skin cancers. And then the request is there to provide medical documentation for the rationale. We don't think that's appropriate given the nature of this device and the efficacy of it. What we propose instead of that is, number one, the use of high-resolution ultrasound is reasonable and necessary for tumor staging and pre-planning purposes to determine the depth, size, and stage. So that's the same. The change comes in number two and number three. So in number two, it says the continued use of high-resolution ultrasound during the fractionated treatment sessions is reasonable and necessary in low-risk and high-risk non-melanoma skin cancers. And so that's absolutely critical, and I'll go into that more, why that is the case. And then number three, the use of high-resolution ultrasound is reasonable and necessary to confirm the biologic response of the tumor during therapy and confirm the absence of the tumor after radiation therapy has been completed. That's very important to physicians and patients. So the role of high-resolution dermal ultrasound, I'm going to boil this down to the simplest possible explanation to try and gain some clarity for everybody here. So the proposed LCD assumes that non-melanoma skin cancers do not change during the therapy, so there's no need to use ultrasound imaging prior to every treatment. The actual truth is that the non-melanoma skin cancers do change 92% of the time during image-guided SRT, according to a study by Stryker et al. And that results in changes, right? So the changes in the tumor size and shape change 92% of the time. And of those changes, those result in changes in the radiotherapy treatment plan, right, for about 40% of the time. And that's basically adaptive radiation therapy, right? If the tumor changes, we can make a response that compensates for that change. So the two ways that these non-melanoma skin cancers change during image-guided SRT are they get bigger and they get smaller. And so that's really important because when a tumor is getting bigger than it was the last time we saw it, we may need to adjust the dose upwards to compensate for that enlargement. And that's significant because when we do that, we're ensuring that each time that the tumor receives a dose of radiation, it's being radiated uniformly and all the way to the base of the tumor. So it ensures that the tumor is entirely radiated each time we give a dose of radiation. And what that leads to is 99% tumor cure rates. When we see the tumor getting smaller, on the other hand, we have a chance to actually make the dose smaller if that's appropriate. And that may not seem very important, but there is a guiding principle of radiation safety called ALARA. And ALARA stands for as low as reasonably achievable. And what that means is that it's important for your patients, they need to be avoiding exposure to radiation that does not have a direct benefit to the patient, even if the dose is small. Okay, so on page 317, there is some information here about coverage guidance. And here's what the proposed LCD says. More recently, there have been some reports of combining the use of image guidance via high-resolution ultrasound and SRT. And basically, the comment is that this is a modality that is currently under active investigation. And in citing this investigative status or under active investigation, there's 6 references that are listed below. And I want to talk about what those references say. So when you look at the 6 studies, what you find is that the majority of them, right, clearly cite ultrasound as the reason for the improved clinical efficacy of image-guided SRT. Historically, the medical literature describes cure rates for non-melanoma skin cancer treated with traditional SRT, so no ultrasound guidance, just the old SRT device. And those cure rates range from 90 to 95% across multiple studies. The reference studies all indicate that image-guided SRT cure rates are improved by the use of ultrasound guidance during therapy to the tune of 99% cure rates for all the non-melanoma skin cancers across multiple studies. There is a study by Goyal et al. That describes the benefit of ultrasound with electronic brachytherapy, which is completely different than image-guided SRT. However, they thought it was useful for staging prior to therapy and for determining tumor clearance after therapy. However, that study did not address the use of ultrasound prior to delivery of each fraction during the radiation therapy. So it fails to address the issue of image guidance. The real problem with these studies is the one by Ballester-Sanchez. This study really creates a false impression. By itself, the study suggests that there is no agreement between skin cancer depth measurements collected via punch biopsy and histology versus ultrasound. And that's a really important distinction to make. And the Ballester-Sanchez study is actually very misleading for 4 reasons. Number one, if you go to the limitations in our study section of the Sanchez study, it notes that the accuracy of the results is suspect because the 3mm punch biopsy technique actually could remove the deepest part of the tumor before the ultrasound is measured. And what that would lead to is it would significantly reduce the depth of the tumor prior to the ultrasound imaging. So you're getting a skewed sample there. You're not looking at the right issue. So this issue led to an erroneous data set in which the ultrasound depth measurements appear thinner than those of the debulked histology. So the tumor was there, the punch biopsy took away the deepest part of it, changed the depth of it, and then it got measured erroneously because of that. In the second place, that punch biopsy technique is not as good as excision for measuring this kind of thing, because when you excise something, you can put the anesthetic around the tumor, away from the tumor, so that it doesn't distort the shape of the tumor before you measure it. But in this study, they injected anesthetic directly into the tumor, distorting the shape of it. They didn't make any mention of how much local anesthetic they injected. They didn't make any mention of the period of time between injection and the biopsy procedure. And so this obviously led to an erroneous data set in which the tumors were expanded by anesthetic, local anesthetic, and that caused the histology depth measurements to appear thicker than those of the histology, and that's exactly what their data showed erroneously. Third, most of all the published non-melanoma skin cancer studies in the literature comparing the histologic depth determination of the tumor to that of ultrasound they all use surgical excision, except for that one study by Sanchez. And that's because the surgical excision, the anesthetic can be injected at a distance away from the tumor rather than be injected directly into the tumor. So if you excise these lesions before you measure them, then you're going to have fewer errors. And so this whole study is suspect because they distorted their tumor and they caused situations where it was not accurate. Fourth is a review article by Laverde et Sod, and Laverde et Sod is a big review of all the studies that looked at measuring basal cell carcinoma thickness with ultrasound. And it really provides the proper context because it looked at all of these studies that we're talking about now. And what they found was that of the studies exclusively comparing ultrasound depth to histopathology, 6 of the 7 studies reported a moderate to strong correlation. The systematic review goes on to specifically call out the outlier status of the Ballester-Sanchez study, stating a single study that found no significant association between ultrasound and histopathology depth used punch biopsy, while all others used full excision. So they're calling this out as an outlier. It doesn't fit with all the other data. And so the validity of the Ballester-Sanchez study literally evaporates when you view it in the context of all of these other studies that I've listed here. These all reveal a moderate to strong correlation when you're comparing the depth determinations of non-melanoma skin cancer via ultrasound versus histopathology. So we'll put that to rest. Those are the end of my comments. I'll take any questions now if required or at the end of the presentation today. Thank you.
All right, thank you, Dr. Ladd. Let's go ahead and move on to the next speaker, Dr. Yu.
Thank you very much for the opportunity to present at this open comment. My name is Leo Yu. I'm a board-certified radiation oncologist. I'm also the chair of research for DART, the Dermatology Association of Radiation Therapy. I'll do this in 2 parts like Dr. Ladd, first part in the morning and second part in the afternoon. Today in the morning, I'll do an overview and guidelines and the big picture on treating non-melanoma skin cancer non-surgically. Here are my qualifications. I have a degree in molecular biophysics and biochemistry from Yale. I did my training in radiation oncology at Beth Israel Mount Sinai Medical Center, and I was fortunate enough to do numerous rotations at prestigious cancer centers such as Memorial Sloan Kettering, Dana-Farber Cancer Institute, and Brigham and Women's Hospitals. And I've learned from some of the best minds on oncology in the country. After residency, I was a teaching attending at Montefiore and Einstein Medical Center. And thereafter, I had a long 15-year career at Good Samaritan Hospital as the chief of radiation oncology. Subsequently, I was the clinical director of radiation oncology at Eastchester Center for Cancer Care and Western New York Cancer Care. I've authored numerous articles and chapters on the treatment of head and neck cancer, including skin cancer, and I've published the largest studies on SRT and IGSRT for non-melanoma skin cancer, and I presented nationally and internationally. I'm a consultant to Skin Cure Oncology. Here's my motto with regard to treating patients. Do unto others what you would do to yourself or loved ones. And I've learned from my mentors early on that you really need to do the right thing for the patients. And you want to look at yourself in the mirror the next day and know you did your best, because they're putting their lives in your hands. And we in the medical field should really feel this responsibility. And in that vein, I was very frustrated as a radiation oncologist for many, many years regarding skin cancer treatment, because we would only get an occasional train wreck case where the multiple surgeries failed, and the dermatologists or the Mohs surgeons threw up their hands and said, oh, well, we can't do anything about it. Go to the radiation oncologist, okay? And for years, I couldn't convince dermatologists to send the patients for effective and cosmetically and functionally superior non-surgical treatment with high cure rates. So I was complaining about this years ago to a friend of mine who happens to be related to my brother-in-law, about how we don't get these patients and they can be cured without surgery for their non-melanoma skin cancer, but they're not sent because it really boils down to money. So is it Providence? 15 years later, IGSRT has now brought back the super effective non-surgical treatments to the patients after decades of absence. I'm going to show that the studies in the guidelines indicate that IGSRT is fantastic and appropriate for both non-surgical and surgical non-melanoma skin cancer cases. With regard to guidelines, they all agree that radiation therapy is a viable primary treatment for non-surgical non-melanoma skin cancer candidates. NCCN, the AAD, the ASTRO, and I put asterisks next to AAD and ASTRO because they have biases based on turf battles and money battles. Guidelines also show that RT is a viable primary treatment for surgical candidates. Most agree. The NCCN, ASTRO, AAD agrees with some provisos. Radiation therapy is really not just a viable primary for non-surgical candidates. In fact, radiation therapy in the form of image-guided superficial radiotherapy has become the standard of care for the treatment of early-stage non-melanoma skin cancer because the studies, clinical experience, and patient preference and internet searches. The AAD and NCCN guidelines all state that radiation therapy is a viable alternative to Mohs for patients that do not want surgery, and the decision should be left to the patient and their physician. AAD deems patient engagement as important, and we agree. The AAD guideline further says that radiation therapy can be used in special circumstances in which surgery is not feasible, contraindicated, or not preferred by the patient after discussion of risk and benefits. Now, the Dermatology Association of Radiation Therapy, we have guidelines that will be shared in the comments. We are specifically only dealing with radiation solely for derm patients. The other society, they have to deal with psoriasis or lymphomas and breast cancer, prostate cancers. So we are very narrowly focused, and it's really good for the patients. One top priority is to allow access to the most effective modality, which happens to be IGSRT at the present time for derm patients. And we advocate for their wishes for a high cure rate without unnecessary surgery or the effects of it. Now, having said that, the guidelines should not be used to make policy. All of these societies, organizations have disclosures and disclaimers. They all recognize that it's not inclusive of all of acceptable treatments and that decisions on treatment should be left to the physician and patient. And they're outdated as soon as they're published. So the LCD that was published had many instances of omissions, distortions, and frankly were wrong. And they will be all addressed in the written response. I want to touch upon a few main points. And by the way, there were 2 pages using the wrong practice standard. It should be ELS, which is electronically generated low energy sources, which is for SRT, and not IGRT, which is image guided radiation therapy. So the LCD error, that one of the main ones that should be and addressed, and Dr. Ladd mentioned this, that's it suggested that only radiation oncologists should treat patients with radiation for non-melanoma skin cancer. That makes no sense. The reality is, from my experience also, that radiation oncologists do not or rarely get to see any non-melanoma skin cancers because the derms have the control. And radiation oncologists as a whole has very little knowledge or experience with skin cancer patients. For instance, they would not know, most would not know, the difference between micronodular versus superficial multifocal basal cells. Medicare data in 2021 shows that only 10 radiation oncologists used SRT and none with IGSRT. So in terms of referral patterns, it's unlikely that the derms will send all their eligible non-melanoma skin cancer patients to radiation oncologists for SRT or IGSRT. And the reality is that 96% of non-melanoma skin cancer treatment with IGSRT or SRT are done by non-radiation oncologists. In fact, most radiation oncologists don't even have an SRT machine in their facilities. They gave this up a couple of decades ago for their $5 million linear accelerators. So it's not really sensible, practical that only radiation oncologists can treat non-melanoma skin cancer with SRT or IGSRT. That's kind of like saying the Pope has to marry everybody himself. In terms of AAD guidelines, here are limitations and biases. They're often influenced by most surgeons who don't have IGSRT. The ones that who do, they really love it, and the patients love it. The American College of Mohs Surgery desire is to do Mohs on all possible skin cancer patients. It's kind of like if you have a hammer, everything looks like a nail. And they still have a widely held false belief that all non-melanoma skin cancer should have surgery because it is, quote, the best. That's not true any longer. In fact, here, American College of Mohs Surgery issued a handout to their providers to give to referring physicians, comparing SRT, which is old, to Mohs surgery. In the circle, you see that they showed the lower, the higher, or the recurrence rates, okay, which is higher than Mohs. But in fact, the IGSRT basal cell 5-year local control is less than 1%, is 0.76 in the trans study. But IGSRT was put in here, kind of mixed in here. And they published this. This is in the back of the handout. Again, citing the old recurrence rates for SRT, but IGSRT has a 5-year local control, local relapse rate of 0.8%. Okay, in fact, IGSRT is better than Mohs, less than 1% versus here 1 to 2.5, 2.6 to 3.1. And this actually was a study that was published in Clinical Translational Radiation Oncology last year. So Astro guidelines have limitations and they have ulterior motives. Their overriding goal is to preserve their codes, because sadly they don't see these patients. They don't really help these patients, but they want to maintain their reimbursements for the other populations for the providers. And that hurts the non-melanoma skin cancer. And Astro actually has a hand in the ridiculous proposed guideline that was published that said that radiation should only be administered by Mohs trained dermatologists, really, or radiation oncologists. And this is kind of like saying only cars should only be sold by horse carriage makers. And this actually cuts out general derms who have done this for over 100 years. And in the bottom of the paper, it said, "We greatly appreciate David Adler, MD, Astro Advocacy Vice President for input. His suggestions were incorporated and improved this manuscript." Astro guidelines, the one that was cited all over the place, it had a disclaimer that is based on information available at the time. There may be new developments that are not reflected in this guideline. In fact, no IGSRT articles were cited, but they made a statement of pure conjecture based on no evidence that daily imaging is neither necessary nor useful when treating with electron beam ELS or skin surface brachytherapy. However, there were no IGSRT articles that were analyzed nor even published in 2019 and 2020. And since then, multiple IGSRT articles published on greater than 5,000 cases had a 99+% control cure rate using daily imaging. So I want to just take the last few minutes to talk about the optimal treatment for non-melanoma skin cancer. They should ideally consist of the 4 C's: high cure rate, low complication, good cosmesis and function, and convenient. And the 5th C, which is important, the cost effectiveness. IGSRT can treat multiple lesions in one session, which is very cost effective. And patients know this. They know what's good for them. They flock to IGSRT locations. Imagine if you had a lesion on your nose or your face, what would you do? Here we have a patient with a lesion on the nose, on the ala, right ala, and it's a basal cell. It was treated with IGSRT during treatment, last treatment, and then after treatment. The tumor is gone with excellent cosmesis and no surgical defect. And by the way, this is a micronodular, which is a high-risk basal cell. I looked at the internet. I found the best results on a similar location. Here we have a lesion, and the Mohs was done here. It looks pretty good. A nice result, but there's still a scar. You see the scar here? And there's still some asymmetry. Was it really necessary for this patient to have this surgery? With regard to Mohs versus IGSRT, you can have dramatically different outcomes. Here's a patient, one of the earliest patients we treated, that had Mohs on the right side, and he had a flap that failed, unfortunately. Okay? On his left side, he had IGSRT. Okay? And look at the results. He's cured, but was surgery really necessary? This guy has to walk around with a part of his nose missing. This is the end of my presentation for the first part. Happy to entertain any questions so far. I'll continue on in the second part in the afternoon, session J.
Thank you, Dr. Yu. If we can go ahead and have Dr. Scott do his presentation.
Okay, just by way of introduction, my name is Jacob Scott. I'm a physician scientist at Cleveland Clinic. I'm a board certified radiation oncologist and established NIH investigator in cancer outcomes and novel technologies. My specific interests research-wise lie in new radiation technologies and really bringing technology to our patients in order to enable better care across the board in any cancer situation. I also have a fair bit of other training, including a PhD in mathematics from the University of Oxford, which I use, the skills from which I use to apply to cancer outcomes and research. And in particular, we're going to talk today, and I want to focus today on a few things. You can do the next slide, please. I want to focus in particular about some of the proposed changes here in the LCD from Palmetto, determining how we think about image-guided surface radiation therapy. And I want to just give a really broad picture before we start. There's some words here you can read, but the most important thing to really think about from a large perspective is that IGSRT is a brand new technology. This is only a 5 or 6 year old technology. And what it does is it takes an old technology, which is SRT, and it brings it into the modern age. In radiation therapy, my field, no one treats without daily image guidance, no matter what, because we really use, we know that tumors move, we know that tumors change in size, we know that we have to see what we're treating, and really it's not no longer done in a conscientious way to treat without such a thing. And I think what we're doing is we're having a trouble in this certain setting because we're talking about radiation therapy, and so who's been brought to the table previously are radiation oncologists, but really this is a dermatologic procedure. In particular, SRT has been delivered by dermatologists for over 100 years. Actually, radiation therapy for skin cancers that we're talking about has been delivered for longer than radiation oncology has been a specialty. And one of the problems that we're running into is that what's happening is that the quote unquote experts who are brought to the table to determine this LCD have been radiation oncologists, when in fact, it's dermatologists who are really the experts in this setting. And I'm going to focus on one or two specific points with this in LCD, which we, and I say, in this case, I say we, meaning the Dermatologic Association for Radiation Therapy, which is an academic association which has been formed to understand best practices for SRT for skin cancer, really looking at a couple of things when it comes to really who is using this technology and who should be, who is most appropriate to make expert decisions. So in particular, we're going to talk about a couple of points made, which is that training and expertise for IGSRT must have been required within the framework of a residency or fellowship program, which is in this case impossible because this technology didn't exist before the vast majority of practitioners were in practice. And if you want to think about that in terms of skin cancer, Mohs is a great example. When Mohs was invented, the vast majority of dermatologists were already in practice. And so it was impossible to go back to residency. So this is just a silly point, I think, that we need to rectify here. And further, we need to talk about the fact that IGSRT is really a different modality than its predecessor, SRT, because really we need a whole multidisciplinary team involved. This is standard of care in radiation oncology. I am a radiation oncologist, but I can't possibly deliver the high quality radiation that I do on a daily basis without other members of the team, including radiation therapists, medical physicists, and dosimetrists. The same is true for IGSRT, and we're going to talk about that. And then further, the last point we're going to talk about today is that really this new technology, IGSRT, brings to the vast majority of our patients who have NMSCs who live in rural America an unbelievable modern technology that allows for cure rates that are similar to or maybe even better than Mohs surgery, which is not available in the vast majority of the country. Next slide, please. So again, we're going to hone in on some of the details. That was what I just gave you was an overview of the whole discussion. In particular, there's a couple points here. In the NCCN guidelines, if you look, currently, we've actually made a recent edit to describe that, IGSRT previously was discussed that the appropriateness for this radiation should be determined by a radiation oncologist. But in reality, these are cancers that are treated by dermatologists. Radiation oncologists, of course, we are trained to treat these cancers, but we don't see them. More than 90% of these early stage cancers that we're talking about, which by the way, are the most common cancers in the world, are treated by dermatologists. And these are treated in the office. And it's an enormous burden for some of these patients to go to a cancer center. And it's just absolutely unnecessary and should not be required. And so what we've suggested is that this be changed from determined by a radiation oncologist to determined by a treating physician. And in reality, that treating physician is going to be, in more than 90% of the cases, a dermatologist. Next slide, please. Oops. Yeah, there you go. And I think this is just a quick visual that shows how this new technology is really being taken up. Again, just to remind folks who aren't familiar, SRT, surface radiation therapy, is kind of a blind procedure, if you will. It's given without any image guidance of any kind, but it's been done for 100 years, so it's well established. And this is a technology that most radiation oncologists are familiar with. The addition of image guidance is newer, again, only 5 or 6 years old. And what you can see in this graph here is that red line is where radiation oncologists lie. Almost none of this therapy is given by rad oncs. And what you see in the blue is the appropriate uptake of this brand new technology by well-trained dermatologists who are now giving the lion's share of this therapy across the country. And in particular, again, this is a therapy that's been given for 100 years, but now it's given in a modern way. Just like before Mohs surgery, we were doing blind excision of these cancers with something like an 85% cure rate, and now Mohs takes it with imaging up to 95. Similarly, blind SRT, given for over 100 years, as you know, was sort of around 85 or 90%. And now that we've added imaging, and you can see this uptake by the specialists, we're now up to 95 or even 99% in many studies. Next slide. So further, I just want to sort of hammer this point home. When it comes to the qualifications of the provider who should be giving IGSRT, using radiation oncology guidelines is not applicable and inappropriate. And really, we should be thinking of this new technology as what it is, which is a tool for dermatologists. In particular, new technologies and therapies come to market every day for practitioners who are already in practice and have completed training. To require folks to go back into training is absolutely ridiculous and has never been done in any other part of the medical specialty world. And to require such a thing is actually antithetical to new technology development. Next slide. I think that there's some details here that you can read, but I think the most important take-home message is that the addition of image guidance to surface radiation therapy is a real game changer, and it's brought us into the modern era. And in particular, this new therapy really brings in an entire multidisciplinary team, which includes physicists, radiation oncologists for general oversight, and dosimetrists to really work together. There's an opportunity for weekly grand rounds for larger discussions, for more difficult cases, and quality assurance in a similar way that we do in cancer centers. But again, the most important thing to remember is that this is really what is done in a dermatologic office by experts in the care of skin cancer patients, especially for these early stage lesions. But the addition of image guidance and the multi-D team really brings this into the modern era. Next slide, please. And I think that once we now have the ability to deliver equal or maybe better cure rates for these patients to Mohs cancers, compared to Mohs surgeries, we have to now look at who's now able to access these care. And the point here is within the Palmetto coverage area, but also nationwide, the majority of patients who are suffering from these cancers live in rural areas. And you can see here the numbers. That's really the vast majority of folks live far away from a cancer center. They live far away from a Mohs surgeon. In particular, many of these places have no access at all. And what the addition of image guidance to SRT provides is the opportunity for general derms to provide modern day care with 99% efficacy, even within rural areas, and the opportunity for virtual oversight, which we have, of course, in this modern era. Here we are in a Zoom meeting together. This opportunity for this oversight really allows that multidisciplinary and specialty care to be given to all Americans, no matter where they live, and of course, other folks within the world as well. Next slide. So I think, what I really wanted to just hammer home is that IGSRT provides a much needed solution for rural general derms and their patients by providing this oversight from a multi-D team, including radiation oncology support at a high level, radiation therapists who deliver the therapy every day, medical physicists who are involved at every stage, and dermatologists who are the experts in skin cancer, providing it to the new standard technology to safely and effectively deliver what is equivalent or I gently say potentially better even cure rates compared to Mohs for folks really where they need it. So we're giving the right treatment to the right patient where they live and where they need it. And without the addition, we really suffer. And so patients will really suffer without this possibility on the table. Next slide. And so again, this is sort of a high level summary. I think that the addition of image guidance, it is delivered with an FDA cleared device. It is a new technology. It is the current proposed changes really don't take into consideration any of the appropriate research, which shows that this is the new standard of care. And the use of daily imaging is really what's brought this into the modern era. And I think that what we're doing is putting patients at risk, either for unnecessary harm, for procedures they do not need, or for outdated modalities which don't provide the cure rates that we know we can give today. And I think it's really the burden is on us as physicians to ensure that these new technologies and cure rates come to all of our patients across the world. And I think I just really want to end there and really just make sure that we're focusing on the right thing at the end of the day, which is delivering high quality care to patients where they live, what they need, and moving forward as oncologists. Thanks.
Thank you, Dr. Scott. If we can proceed with the next discussion by Dr. Smith, please. Thank you.
Okay, I'm here. I am not a doctor, but I am a patient. So thank you for allowing me the time this morning to speak with you. And I'm speaking, I believe, on behalf of hundreds of thousands of patients as I go through this. Deb, could you go to the next slide? As I said, my name is Peter Smith. I would like to start by just giving you a little bit of my background. I have worked in healthcare my entire career. Why was I motivated to go into healthcare? Pretty simple thought. My feeling was that innovation is wonderful in our society, but particularly important in healthcare. Just imagine a world where we have the level of care that we had during the Civil War or even before that. It's basically unimaginable. And how did we get to where we are today? It was all through innovation. A couple of examples of things that I've been involved in is taking infusion therapy out of the hospital where it used to be solely practiced into the home, which has been a huge improvement for thousands and thousands of patients. Taking a wound management device into an ambulatory mode, which has been tremendous for patients who have difficult or impossible to heal wounds. The use of artificial intelligence and smartphone technology for a new product that allows us to screen large populations for skin cancer, which never happened before. And the common thread in all these cases is assembling both the technology and the service, but most importantly, the policy. I remember back in infusion therapy where people opposed this, and we had to get the data put together and the learning curve and the education so that people would make the changes and so on. So I'm very familiar with introducing something that's new and innovative, and that leads me into the comment, and I will later explain, but I am both an investor in and a board member of Skincare Oncology. And as you hear my story, I think you'll know why I'm very proud of that. So today I'm going to share my story as a skin cancer survivor in hopes that it will inform your policymaking. And thank you in advance for listening. Next slide. So this goes back to my 20s and 30s, and I will reveal that I am 76 years old right now. But at that point, I began to realize that I was not only at risk, but more at risk than almost anybody. Both of my parents had the wrong kind of DNA. They both were treated extensively by Mohs surgery for various both melanoma and non-melanoma lesions. And my father was a very compliant person. At the end, my mother absolutely refused any more Mohs surgery, unfortunately, but they had more than their fair share. When I was young, I did a lot of things that we all like to do in the sun. I like sailing, fishing, skiing, golf, tennis, hiking in the mountains, etc. And I put myself out in the sun quite a bit. Subsequently, I joined the U.S. Navy on a destroyer out at sea for many months at a time, and we got more than our fair share of sun there. And throughout all of this, I really was in an era when there was no great protection. In fact, my mother used to use baby oil, and I later found out it might have been better to do nothing at all. But basically, I didn't have the benefit of all the wonderful skin screen protection that exists today. So I began to see a dermatologist in my 20s, and they told me that I was going to have a lot of trouble in life. And of course, I listened, but it was sort of a theoretical set of comments, and so I absorbed some of it. But at least I kept seeing the dermatologist, and then in my 40s and 50s, the risk began to play out, unfortunately. I had my first squamous cell at age 46, and that resulted in a Mohs procedure. Of course, at that time, the only thing that I was offered or understood was available was Mohs. And that impacted me. I certainly took note of the fact that I went through this whole process. Nothing went wrong with the Mohs procedure. But with the help of my wife, I began to think about changing my lifestyle and made a major effort to start covering up in the sun. And the other thing I did in my early 30s was to increase the screening with my dermatologist. I went from one visit a year for the eye skin exam up to 2 visits a year. So from age 46 to 59, I had, unfortunately, a continuous flow of additional squamous cells. There were a total of 7 more cells, and they were all treated with Mohs. I guess I was an equal opportunity provider wherever they occurred, because I had 2 on my forehead, 1 on my shoulder, 1 on my face, 1 on my neck, 1 on my leg, and 1 on my back. So it taught me that these could occur anytime and anywhere, and that I needed to keep up my close screening with the doctor. Next slide. When I look at my treatment for all these cells, I guess I would say that my experience was not as bad as others that I know. I know people who have been required follow-up plastic surgery. I know people who have been disfigured by Mohs surgery. I know people who have had tremendous wound management problems, much greater than mine, which I will describe. I know people who have had infections. So, you know, when I look across the spectrum and I tell you a little bit about what happened to me, I fall probably in the middle zone. For example, my forehead Mohs surgery, when I was getting stitched up and it was complete, the surgeon said to me, "You're going to be a little uncomfortable because there's not a lot of skin up here to work with." So we had to tie the sutures very tightly. Well, I could still remember going home, and I never slept for 3 days, despite all of the pain pills that I used and everything else. It was just excruciating. And also, that surgery was such that it needed the stitches to remain in for 3 weeks. So I lived with sort of this miserable feeling on my forehead for a total of 3 weeks. And that involved wound management, you know, every time I took a shower, having to tend to it, etc. Next came my shoulder. And when the time came for my stitches to be taken out, which was 2.5 weeks after surgery, the wound was still bleeding, had not closed, etc. And of course, I was informed that the shoulder is a very active area. And the best way for me to follow up and get the wound to close would be to immobilize my shoulder, which I attempted to do. This was probably one of the scariest things that happened to me, because along the way, the punchline is it took me 4 more weeks of wound management to finally heal the wound. But along the way, I kept thinking, I wonder if this is ever going to close. And it was difficult because I couldn't use my shoulder, or every time I did, I caused myself a problem. Next came my leg, and I was told right up front that this would be a slow healing wound because of the circulation in the area. Well, it was. I mean, it turned out to be another 4.5 weeks, and a total after the stitches came out, so a total of about 6.5 weeks of wound management. But at least this time I felt like it was going to heal, because I'd already had the previous experience, so I was a little less freaked out. The last one was when I had my back surgery with Mohs. I arrived a few minutes before 9 a.m. for the procedure. As we all know, with Mohs, you get cut on, and the results are taken to the pathology while you wait in the waiting room. And until the margins are cleared, you keep going back and forth to get excisions. And that day, it took 4 different sessions to get all of it out, and the margins finally were clear, and I was sewn up at 4:30 p.m. So I spent the entire day in surgery. These are things that I just, you know, weared on me. And of course, the biggest thing was the wound management that followed. Next slide. Unfortunately for me, in my 60s, my problems actually accelerated. I had another 5 squamous cells, and an additional 2 basal cells. So by the time I had reached the end of my 60s, I'd had about 15 Mohs procedures. And what was beginning to happen with me was just, I will describe it as a form of depression about the whole thing. I knew that the right thing for me to do was to keep going in and seeing the dermatologist for the eye skin exam, which was the right thing for my health and well-being. And using this company that provided the screening product was helpful as well. So I was doing the right thing, but at the same time, I was just absolutely in fear and trepidation every time I went in, because I knew there was a good likelihood something would be found, and then I'd have to go through Mohs surgery again. And of course, I had looked around for any other alternative, and I had not found anything. So there was no light at the end of the tunnel. And boy, it was just a bad era for me. And, I've been lucky with the rest of my health, but this was really affecting me. Next slide. So here are just a few pictures. You could find thousands of pictures of different patients going through Mohs surgery. And that was kind of just a little representative of my few pictures that I kept. But I have an afternoon slot, and so I thank you for listening to me this morning. What will happen this afternoon is you will hear about the redemption of IGSRT and what it's done for me and my life. And so I appreciate it, and I'll look forward to talking to you this afternoon. Thank you.
Thank you, Mr. Smith, for your presentation. We have about 8 minutes left if Dr. Tenner would like to get back on and do his presentation.
Yeah, hello, this is Steve Foster.
I'm sorry,
and
Dr. Foster, I apologize for saying the wrong name.
No problem at all. And I'm an industry guy, so not a doctor, but I very much appreciate the chance, and I promise to be very concise here. If I could be given the ability to share the screen, I'll share. Okay, hopefully everyone is seeing that fine. Again, I'm very appreciative. We had a power outage here and I'm on a cell phone bridge now, and things appear to be stable, so I think we can get this done. Again, my name is Steve Foster. I'm the CEO and president of Tenon Medical, and I appreciate the opportunity. The purpose of the presentation is to focus on classification questions specific to SI technologies. The proposed LCD has directional implications that I'd like to discuss and make sure we clarify. While many intra-articular devices utilize posterior or dorsal approaches, several utilize posterior and or inferior posterior approaches to transfix the joint, as determined by FDA testing and 510K clearance. It's very important to highlight, and I believe Dr. Sowen addressed this earlier, that the AMA has reinforced that transfix is not a directional component, and it is defined more by FDA's review and their approval of these devices. If we look at codes 27278 and 27279, they are non-directional, as I mentioned, and the terms transfix was introduced by CPT during their 2022 May editorial meeting. The only real distinction between 27279 and 27280 is this, 27278 is whether or not a transfixing device has been placed. This is all other aspects of the code descriptions and the vignette and what have you have remained consistent. These are the real distinction between the two. And so we focus on these terms and what they really mean, right? And the terms are very different, with transfix referring to piercing, spanning, and holding motionless, while intra-articular refers to being within the joint. The important component here is the AMA has discussed this on several occasions and confirmed that transfix is not a directional guide, nor is direction contained within procedural descriptions or clinical vignette with these codes. So just by way of simple example, here are several of the intra-articular devices that are out there now and available. And these are very clearly technologies that are placed within the articular joint and are not transfixing in nature. By contrast, this is an example of a transfixing technology that's placed via an inferior posterior approach and is summarized here. After appropriate joint prep and graft harvesting, an implant is placed that is a full 90% of the volume anchored in sacral and iliac bone. And we conclude here that by any reasonable definition, this is a transfixing device. And these steps, of course, produce radiographic confirmation via 12-month post-op CT It reinforces that well-established principles of arthrodesis have been followed and achieved. As these slices proceed, you'll note clear evidence of bridging bone with this particular inferior posterior approach. I know everyone is short on time. I want to be very succinct. I'll leave it open to any question, et cetera, and I very much appreciate the time and the opportunity to comment.
Thank you, Mr. Foster. That is all the presentations. Melissa, unless there's any ongoing questions or further discussion, I believe that ends all the presenters.
I don't have anything else, Dr. Trunis.
Okay, then I want to thank everybody for doing their presentations, and this will conclude our open meeting. Thank you.